So, okay. So when we enter into the room, again, we will start with the hand washing. And I will say that I'll go to the patient side and I will find out the instruction, what the instruction says, because it's very much important. Say, if you just, from my experience, if you went into the exam room and it is said this gentleman is having itching, and you'll found there is a lady of 35 or 25 years, and when you exam, you found nothing but spider nevy, you are very much sure this is the case of PVC. So after entering into the room, your main aim is to identify what is the instruction. And after that, you wash hand and introduce you to the patient. Just say, hello, I'm Dr. Rahman. I'm one of the doctor of this clinic. I would like to examine you. Is that okay? Do you have any pain anywhere in your body? No. During my examination, if you feel any pain or discomfort, let me know. I will be gentle. Then expose the patient. For proper exposure, always ask the patient, would you please take off your shirt, please, or gown, please? Actually, patient is already well informed, and he will help you. He will take off his shirt by himself. Or in case of the female, there will be a female attendance. Just say the female attendance, I want to do proper exposure. If you say this, the attendance will be done. And if you think this patient is too poor, too elderly patient, and he is old, at that time you can help him. May I help you to undress? Then during the exposure, your main aim is to identify the scar. Because so during exposure, again, your main aim is to identify the scar, mostly renal transplant scar. If you find this scar, your examination technique will be different from the other things. Okay, so main aim is to identify the scar. This scar is very easy to see. So just when you lie down the patient, when the patient lie down or in the supine position, check carefully, is there any scar in the right iliac fossa present or not? Because sometimes it's happened that patient trouser may be above the umbilical, so you will not find the scar. So your aim to visualize the anterior up to anterior superior iliac spine, just below the anterior superior iliac spine, so that you can see any scar in the right or left iliac fossa. So it's very much important, because if you find this is a renal transplant scar, you have to see a lot of things along with that. So after that, what you will do a simple general observation of the patient. Just at a glance, you see the patient, and you see the patient abdomen as well as the face and the arms. It's a general at a glance. Then you will start your examination from the hand. From the hand, just you will say, may I check your hand, please? Patient will give his hand. In the hand, what you will see in whole examination, you will see stigmata of the liver disease. Okay, so in the hand, what you will see is there any palmar erythema present or not, or any Dupuytren contracture, and at last you will see the flapping tremor, any flapping tremor. Think that if you find any scar in the right iliac fossa, that is, there is a scar in the right iliac fossa, then along with that, you have to see some other thing. Okay, what is that? That you will think the skin thinning of skin, or any erythematous lesion over the skin for iatrogenic Cushing. Or here you can also see during flapping, you can see the tremor, because in case of the transplant patient, he will be already on drug like cyclosporine, it causes tremor. Okay, so if you find the renal transplant scar, along with that, you will see skin thinning, erythematous lesion, the skin bruising of the skin, and any tremor. If there is no such thing, no scar, then you only see the palmar erythema, Dupuytren contracture, and flapping tremor. Then go up, and during this, always rub your hand over the patient forearm to find any AB fistula scar. Either this patient is renal or not. Always try to check. So to find out AB fistula scar, that arteriovenous fistula in the forearm, in the both right or left. Okay. So how you will do it? You do just gentle rubbing over this hand. So you will find there is a AB fistula if present. Okay. Then you will go to the, if you find there is AB fistula, then you have to check it is functioning or active. So if you find there is AB fistula may be functioning, and you have to also see the activity. So how you will say this is functioning? Functioning means that through this fistula, you can do hemodialysis. This is the functioning. So if there is any bruit present, then it indicates it is functioning. Okay. Activity means signs of recent use. If you find any needle mark there, then you can say that this is active. Okay. So this bruit may be palpable as a thrill. So you can palpate over the AB fistula. And if you find the thrill, you are very much sure this is functioning. And if you see any needle mark there, you are very much sure this fistula is active. So if you find any AB fistula in the forearm, you have to check either it is functioning or it is active. Then you will go up in the face. In the face, you will check any anemia, jaundice in all stations. If you go to the face, anemia, jaundice. Okay. So you go to the face, mainly eye, to see anemia and jaundice. After that, you will see the oral cavity, always with light. So oral cavity with light. Again here, if you think this is a case of renal transplant, always check gum hypertrophy. And for that reason, just ask to the patient, can you please show your gum, please? Can you please show your gum, please? Patient will show his gum. So if you think this is a case of renal transplant, from the beginning, you see there is a scar. So you have to, during oral cavity examination, just you will check is there any gum hypertrophy present or not. Okay. Apart from this, if this is a case of, if you think that ultimately this patient has hepatosplenomegaly, you are suspecting there may be possibility of a hematological disorder. At that time, gum also very much important. Now you will check the neck. In the neck, you will not do anything. Then you will go to the abdomen. In abdomen, again, inspection, palpation, percussion, and auscultation. At first, what you will do in the inspection. In the inspection, just you will see any other scar present or not. Okay. Just you will see, is there any other scar present or not? And always roll the patient right or left to see any scar in the back. So in inspection, the scar again, and roll the patient right or left to see any other scar. It's possible that this gentleman is having two scars at the same time. One scar from the renal replacement scar, and again, another scar for the nephrectomy scar. Not all the time nephrectomy scar. In case of polycystic kidney disease, where both two is done simultaneously, that renal replacement scar and nephrectomy scar. Sometimes in the polycystic kidney disease, only cystectomy is done to reduce the size of the cyst. And at that time, you will find that there is another scar. This scar may not be as large like renal replacement scar, renal scar, other renal scar, that right lumbar region scar. So always rule the patient right or left to see any scar. Then we'll go to the palpation. During palpation, always think abdomen is a 9 quadrant, and you will just place your finger over the 9 quadrant, starting from this, and you will place your finger, place your hand, okay, and gently rub over the skin. In palpation, this is called superficial palpation. Remember, in superficial palpation, you can identify all the pathology. Okay, mainly in organomegaly. In superficial palpation, you can identify most of the pathology in organomegaly present or not. Okay. In deep palpation, that is organ palpation, you'll confirm what is that. Is it any mass lesion or is it any other organ? It is liver or spleen. But in superficial palpation, just you'll place your hand, finger over the 9 space, that over 9 quadrant of the abdomen. Here you will identify any organomegaly, any mass, or any rigidity, or any tenderness. So you will do the superficial palpation. After that, you will do the organ palpation. In organ palpation, again, starting from the, you will check the liver, then you will check the spleen, then you will check the kidney. So just you will do the liver, then your spleen, or then you will check the kidney. Sometimes if there is any mass, you can do palpation of that mass. Okay. So at first you will do the superficial palpation, then you will do the organ palpation. In case of the liver palpation, just start from the right iliac fossa, place your hand properly, try to palpate the liver over the over the lateral aspect of your finger, that is index finger. Then place your hand, push gently, and ask the patient to take a deep breath. Again, place your hand, push gently, and ask the patient to take a deep breath. Okay. Patient, during this breathing, don't move your hand. Just please take a deep breath, please. Yes. After taking a breath, oh yes. Then again, move your hand up, take it towards the right shoulder. Sorry, left shoulder. Then take a deep breath, please. Yes. In this way, I will examine the liver. Okay. When you find there is a border of the liver, try to palpate the liver as a whole to see any tenderness present or not. Then we can do the check the upper border of the liver dullness. We check the liver bruit at the same time. Then we'll check the spleen. In the spleen, again, you will palpate the spleen starting from the right iliac fossa in this same manner. If the spleen is not palpable, patient is lying in the supine position, you are not getting the spleen. Then what you will do? You will do the right lateral position, and you will you will start the palpation just above the umbilicus. Okay, here you will you have not get the spleen in the supine position, so start the palpation just above the umbilicus. Okay, just you will start from the 2 or 3 finger above from the left costal margin. Then press and ask the patient take a deep breath. In this way, you will palpate the spleen. So first general palpation. If spleen is not palpable, then in the right lateral position. Now you will palpate the kidney. Kidney is always palpate bimanually. So 1 finger up and down, and ask the patient take a deep breath in, and at the same time just push towards the kidney. Left lower hand upwards and upper hand downwards. Ask the patient, please take a deep breath in. In this way, we will palpate the kidney. So I have done the palpation of the liver, spleen, and kidney. Then what we will do? We will check the. We will do the percussion. That means we will check the ascites. So I already, if there is any other mass, then I will palpate that. Okay, or I can palpate at first the mass, just to size of the mass, any tenderness of the mass. Is it intra-abdominal, extra-abdominal? Just we can. Oh, now I'm going to just repeat the kidney palpation. Kidney is always palpate bimanually. Bimanually, that means I will put one of my hand in the just the up the lumbar region. Just I will palpate in the lumbar region, number 1, and 1 finger up and another hand down. And at this, I will ask the patient to take a deep breath. At the same time, I will push inwards. I will push inwards and to I will try to palpate the kidney. Okay. An interesting thing is that if the kidney is palpable, that is mildly palpable, it will not given in your exam. Okay, yeah, it's just like amyloidosis, hydronephrosis. If it is mild, it will not give an exam. If there is a if the kidney is palpable, that is amyloidosis, or in the hydronephrosis, it will not give. Mostly cause of the what polycystic kidney is usually given in the exam. At that time, your kidney is so large, sometimes you'll confuse this is a case of hepatosplenomegaly. Okay, so be careful at that time. How you will differentiate? I will say at that time, if you try to bimanual palpate, you don't need to push. If you are asked to take a deep breath, only you will press in the upper side. It will be strike in the lower hand. If you try to push it up, that it will strike in the upper hand. So in this way, you will do the kidney palpation. Now you will do the auscultation percussion. Percussion. Sometimes if any organ is found during palpation, then you can do the palpation at that time. Sometimes if you don't do at that time, you can do during right now. That means in the percussion. But it is good to palpate the organ at the same time, so it is comfortable. So now you will only the palpate for the ascites. Or for ascites, you will check the shifting dullness. So you will start from the you will start from the upper part of the abdomen, that is just below the xiphoid sternum. Then go to the umbilicus, then go to the one side. It may be right or left. Okay. Then ask the patient to shift at that side, shift the other side. So if you go to the right side, ask the patient shift to the left side. Then you will wait for around 10 to 15 seconds to see if you found any dullness. Then you will ask the patient to shift to left lateral position and wait 10 to 15 seconds. Then again percuss to see any change. If there is no dullness, then what you will do? You will do the same thing. That ask the patient to shift, and you will again dull. You will percuss for 1 or 2 times. It will not be changed if there is no dullness. Okay, so you will check only in the one side, because ascites is a free fluid, so it will be present both in the right or left person. Now you will check if you now you will do the auscultation. So percussion. Now you will do the auscultation. In auscultation, there is also 2 types. Sometimes we auscultate over the organ, or sometimes there is some areas like to see the bowel sound. So if there is a splenomegaly or hepatomegaly, we will auscultate over that to see any splenic or hepatic rib. Now, and at the same, lastly, I will auscultate for the bowel sound in the right iliac fossa. Okay. Then I'll check the leg edema. And lastly, if I think this is a case of hepatosplenomegaly and possibility of it is some cases of hematology, then I will ask the patient to sit down and I will check the neck for lymph node. Okay, apart from this, lymph node is not essential. Okay. Now, I think from the beginning, it's a case of renal transplant. It's because if anyone asks what are the most common causes, sort of the most common station in the abdomen, this is the number 1 cause is the renal, and the number 2 case will be the renal, and number 3 is also the renal. So it's very much important. And after that, what you got? You may get other scar. Okay. You may get the CLD station. That means ascites station. Ascites stations is varies because this ascites may be associated with other cause. So you will get ascites station. So it may be associated with splenomegaly or hepatomegaly or any other peripheral stigmata of the liver disease. Okay. And very rarely you can get other organomegaly. That means hepatosplenomegaly, splenomegaly, or hepatosplenomegaly both. And lastly, device. That means in a pack tube, any pack tube. Okay. So again, if you think this is a case of there is a renal transplant scar. This is a renal abdomen. So from the beginning, you have to be careful. You have to check something extra for this patient. And during examination, when you start from the hand, you will check if the hand tumor present or not. You will check the dorsum aspect of the hand for any steroid purpura. That means any bruise, ecchymosis present or not. And you also check for thin skin. And during oral cavity examination, you will check there is a gum hypertrophy present or not. Okay. And during abdomen examination, you will find on inspection there is a scar in the right hypochondriac area. That means scar. And at what you will do at this, you will check the scar. Just you will shift your right to that scar to show the examiner that you notice that. Then what you will do during palpation, it is better. There is abdomen is 9 or so, better start from that area. Okay. And just you will do the at first superficial palpation, then again start from this superficial palpation. You will say just I'm going to gently feel your tummy. Is that okay? Okay. Now I'm going to push more harder in your tummy. Is that okay? Okay. Then palpate the mass, and after that you will palpate the liver, spleen, and the kidney. So and overall, lastly, what you will say? You will say overall the whole skin. Sometimes it's possible that this patient is taking immunosuppressants, sometimes for some viral warts, so you have to check them, or any skin ulcer. Okay. So after that, in case of the renal transplant, when you complete that case, that means you complete to check the leg for edema, you ask the patient to sit down. Sit down. In sit down, why the patient sit down? To check the neck. You will check the neck. You may check the raised JBP, some neck scar, or to check the raised JBP or some neck scar. And if possible, you will auscultate the lung. So you have to do those things extra if you think this is the case of renal transplant. Okay. So again, renal transplant is very much common. So just to recap, what you will see in the renal transplant extra, some hand sign I have discussed already. Then if you can go up, you can say anemia, jaundice, and now you can check the also neck. This time also neck, in the neck above and below the clavicle. Okay, for above or plus below the clavicle, for any previous scar of catheter insertion. Okay, then you can go to the abdomen. You will check the abdomen properly, and after that you check the peripheral edema. Then again sit down the patient, check for any edema, pulmonary edema or basal crepes. Okay, so in case of the renal transplant, you have to do those things extra. Okay, so any question up to this or in this examination procedure or any suggestion?
Sir,
Yes.
Assalamualaikum. Sir,
Walaikum
AV fistula scar we will found on the arm or forearm, and where else we can find?
Okay. So AV fistula scar is always found in the mostly forearm. Okay, right or left side. You can. So just you to try to rub over the screen. Then at that time you will find there is a AV fistula scar. In abdomen station, always be careful with the AV fistula scar, because this may be possible. This patient is only the AV fistula scar. Apart from this, nothing. Okay, only the CKD patient getting the hemodialysis and patient is normal. So you have to check the AV fistula scar. And if any patient have AV fistula scar, just think about the patient natural history. At first, patient develop the chronic kidney disease. Okay, so patient is no follow-up. Patient comes and his serum creatinine is found 10, and he has uremic encephalopathy. What you will do? You will do immediate dialysis through neck. Patient is stable, Now you you done the AV fistula, and to do the regular dialysis through arm, forearm. So AV fistula. Okay. So this is the natural history. Sometimes what can do, if stable, sometimes you can do the peritoneal dialysis. So you may get some abdominal scar also. A very small abdominal scar, small scar. Okay. So those scar is possible in case of the CKD patient, because it is also possible they put the simple CKD case patient on dialysis and there is no other thing. So be aware of the scar in case of the CKD or renal displacement scar. Okay. Any other question? Okay, thank you. So now I will discuss about the renal abdomen specifically. What is the common question and what is the answer and how we will present. So in case of the renal transplant, actually what we have to see, what is the aim, what we will see in the patient. Number one, we will always see that there is a mode of the renal, that is current mode of the renal replacement therapy. Current mode of renal replacement therapy. Okay. So this current mode may be number one, renal transplant. In case of the renal transplant, this is renal transplant or AV fistula or through neck, that is permacath. So current mode of the renal replacement therapy. Think a patient is developing, a patient is renal transplant, his transplant is not functioning at all. Now the patient again developing renal failure. So these gentlemen will have the renal transplant scar, at the same time another current mode of another renal replacement, that is maybe in neck catheter. That means now this gentleman develops a renal failure of the renal transplant. Now there is a catheter in the neck. So it may happen because those patients after dialysis actually usually stable and he can speak and he can do everything. So this patient may come in the exam, but usually it does not happen. They put a simple renal replacement case. Then you will check the previous mode of renal replacement therapy. What is the previous mode? Currently, renal function is dependent on the replaced kidney, but he may be some previous, that means AV fistula scar, neck scar, or some abdominal scar. Okay, for peritoneal dialysis, those are the previous mode of the renal replacement therapy. So number three, you will check cause of the renal failure. Cause of renal failure, if present. Not all the time you will find the cause of the renal failure, but sometime you will find cause of the renal failure. Just like PKD patient, number one. Number two is in a connective tissue. If any patient have SLE or systemic sclerosis, when you check the skin of the hand, you will find there is a systemic sclerosis. This is in SLE patient as well as systemic sclerosis patient, there will be florid picture of the SLE and systemic sclerosis, as it is already involved the kidney and is advanced disease. So at that time, you will find there is a cause of the renal failure. But most of the time, you will not find any cause, as it is most common cause is chronic glomerulonephritis, diabetics, hypertension. So without asking the patient, you cannot identify the diabetes easily. Lastly, you will check the efficacy of the renal replacement therapy. Currently, patient is on renal transplant and how his transplant kidney functioning is good or not. How you will check? Number one is features of fluid overload. Features of fluid overload. Okay, that means raised JBP. Patient has basal crepitation, or patient has peripheral edema. So if the if any patient of renal transplant is raised GVP, basal crepitation, peripheral edema without other organic cause, that indicates his kidney is not functioning at all. Okay. Or at the beginning, we have checked the flapping tumor in advanced case. So if flapping tumor is present, it also indicates his kidney is not functioning. But the thing is that the examiner will ask the question, but if any patient develop a transplant failure, actually he will not present in the exam. And he will find something in the transplant kidney. That means you will find something in the transplant kidney, that is tenderness. Okay. If any transplant kidney develops inflammation, then at that time you will find some tenderness in the kidney. Okay. You get some bruise. You bruise over the kidney due to blockage of the vessel. So some features of fluid overload and something in the transplant kidney. Lastly, you have to check the side effect of the medication. Side effect of medication. So what are the side effects? It may be because every patient of renal transplant usually getting at least 2 or 3 immunosuppression agents, including steroid, cyclosporin, azathioprine, or mycophenolate mofetil. Mostly nowadays mycophenolate mofetil along with steroid and cyclosporin. So what we will get? You will get the patient is already diabetics, number 1, or impaired glucose tolerance. So patient may develop iatrogenic Cushing. Patient may develop tremor due to cyclosporin. So you will to check something about the those things. If any patient takes immunosuppressive for a very long time, he have very common has some viral warts, or some basal cell carcinoma or squamous cell carcinoma. So these also may visible. Okay. So what we will say again: current mode of renal replacement therapy, previous mode of renal replacement therapy, cause of the renal failure, efficacy of the renal replacement therapy, and side effect of medication. Look, among all those things, we will not actually be stressed for this that I have to find out the cause, I have to find out the efficacy. We will do the normal procedure. Among the if it is present, I'll find. Okay. So now I will say how we will present the case. Okay. So how we will present the case. Regarding the presentation, just I will start. If any patient with renal scar, I will start from that scar. Okay. In another interesting thing is that when examiner asks the finding, I will not say that I would like to complete my examination. Actually, they have already given the 6 minutes, and what I have find in this 6 minutes, I will say that. I will not say that I will like to complete my examination by doing this, checking the external genital, digital rectal examination. I will not say this. I will go to the findings. And then another thing is that we will not say any negative finding, because on examination of this abdomen, there is no scar, there is no tenderness, skin condition is normal, and there is no dilated. So I will not say any abnormal findings. Just I will start what I have already given. Okay. So on what I will on examination of this gentleman, always a gentleman or lady. Just 2 things: a gentleman or lady. So not elderly patient. So on examination of this gentleman, there is a scar in the right iliac fossa. So there is a scar in right iliac fossa, and beneath the scar there is a mass. Okay, so below the scar there is a mass, which is around 7 centimeter into 4 centimeter, and it is usually non-tender, firm in consistency, and without any bruise. Okay. So on examination of this gentleman, there is a scar in the right iliac fossa, and beneath the scar there is a mass, and this mass is around 7 to 4 centimeter, and it is non-tender, firm in consistency, and there is no bruise over it. Okay. There is also a AV fistula. We'll say directly AV fistula scar in the right hand. The right hand, what we found, which is functioning, and no sign of recent use. So which is functioning plus no sign of recent use. And there are multiple scar over the neck, as well as if you found any abdomen in the lower part of the abdomen, which indicates the previous access for dialysis. Okay. Now I'll say something about the efficacy. There is no signs of fluid overload. Just one line. I have checked already the JBP, basal crepes, as peripheral edema. So there is no signs of fluid overload. Okay. If any drug feature present, that means iatrogenic Cushing, or a patient is have any skin sore or skin viral wart, I will say that now. But most of the time, I will found there is a simple case. So there is a scar in the right iliac fossa. Beneath the scar, there is a mass which is 7 to 4 centimeter, and it is non-tender, firm consistency without any bruise. And there is also AV fistula scar in the right hand, which is functioning, but there is no signs of recent use. There are multiple scars over the neck and the abdomen, which indicates, that means AV fistula, neck scar, abdomen scar, previous access for dialysis. Okay, and there is no signs of fluid overload. So I will say this as it is very much important. So no signs of fluid overload. Okay, if you found any complication, you can say complication like a Cushing, iatrogenic Cushing. Think this gentleman is having iatrogenic Cushing. So how will say? Again, scar in the right iliac fossa. Beneath the scar, there is a mass which is 7 to 4 centimeter. It is non-tender, firm in consistency without any bruise. And there are also some heavy fistula in the right hand, AV fistula in the right hand, which is functioning and no sign of recent use. Okay, and there is no signs of fluid overload. Okay, and this gentleman is also having some bruising over the forehead or the arm, as well as wasting or thinning of the skin. Okay, so and from the beginning, if you see there is a facial puffiness or acne, I will say this. Okay, there is also some form of facial puffiness as well as acne over the face. Just to say this lady has iatrogenic Cushing syndrome. Okay, so I will say the complication here. If this gentleman has a tumor or viral wart, so I will say also here. Up to this, then there are multiple nodular ulcerative lesion over the whole skin. Just simple. So my clinical diagnosis, this is a case of renal transplant, which is functioning well. So this is a simple case. My case, this is a case of renal transplant, which is functioning well. So this is the so this is the simple description. I will start from the scar, then go to the AV fistula, then no signs of fluid overload, then complications. Okay. Now think this gentleman has polycystic kidney disease, and at the same time he already did the surgery. That means he already did the surgery for the nephrectomy, and after at the same time he did the renal transplant. Okay, so how we will say? Just like on examination of this gentleman, there is a scar in the right iliac fossa, which is measuring about 7 centimeter to 4 centimeter, and it is not tender, firm in consistency without any bruise. Okay, and there is also another scar. We'll add here in that. There is also another scar in the right or left lumbar region. Usually it is done in the right lumbar region to give some space to transplant kidney. Okay. So there is another scar in the right lumbar area. Okay. Now, it important thing is that if any patient is having the polycystic kidney disease, he is bilaterally palpable kidney. Okay, so having the polycystic kidney disease, he will he will be bilateral palpable kidney. Okay, so as I'll say this finding, I'm starting from the abdomen, so I will complete this in the this here. Okay, apart from the scar, there is a kidney is bilaterally palpable. Okay, the kidney is a bimanually palpable, which now if you think this is patient is already done the right-sided nephrectomy, then I will not palpate the kidney in the right side, but in the left side the kidney will be still palpable. Okay, usually nephrectomy done to give some space to the space to the kidney, or sometimes there is a stone, repeated infection, mechanical discomfort. For that reason, patient made out the polycystic patient made out the nephrectomy. Okay, but if it is done in the right side, there is a scar in the right iliac fossa as well as right lumbar region, and then you will be easily confused in the left side. Either it is kidney or it is spleen. So you will be confused in the left side. So kidney or spleen. Okay. So how you will differentiate that is you will say some finding in your in your description that you are very much sure this is kidney. So spleen usually moves with respiration. Moves with respiration, number one. But kidney does not move with respiration. And another thing is that if you percuss over the kidney, it will be tympanic. But if you percuss over the spleen, it will be resonant. Okay. And kidney is always bimanually palpable. That means when you palpate the kidney, you can palpate over the both hand. If you press in the upper hand, it will touch the lower hand, and if you press in the lower hand, it will touch in the upper hand. So it is bimanually palpable or ballotable. Okay, so you will say this finding. And another interesting thing, if you find the if you find this is a kidney, you will find there is a it is possible to find the gate above the swelling. That means if kidney is palpable, you can palpate over the kidney. Okay, so gate of the swelling is palpable. Now, if you say the one thing, I am just saying this the ultimate finding will be polycystic kidney disease. Renal transplant, which is functioning well, and the cause of this transplant is polycystic kidney disease with right-sided nephrectomy and left. So what I will say, look, there is on examination of this gentleman, there is a scar in the right iliac fossa, and beneath the scar there is a mass which is around 7 to centimeter into 2 centimeter or 3 centimeter, and it is non-tender and firm in consistency without any bruit. And there is another scar in the right lumbar region. Okay, and this gentleman is having palpable kidney. Okay, palpable kidney in the left side, which does not move with respiration, and which is bilateral and resonant on percussion, and it is possible to get above the swelling. Okay, now I have complete all the abdomen. I have said there is a renal transplant scar. I have said there is a right-sided nephrectomy scar, and I have said there is only left-sided enlarged kidney. That means no kidney in the right side. That means it is nephrectomy. Okay. So I have completed the abdominal finding. Now I will go to the hand. There is also a fistula in the right hand, which is functioning, and there is no signs of recent use. There are multiple scars over the neck, which indicates the previous access for dialysis. There are no signs of fluid overload. Okay, so so my diagnosis: this gentleman is having renal transplant, which is functioning well. Okay, and cause of this renal transplant is possibly polycystic kidney disease as well as right-sided nephrectomy. So this is my complete finding of this gentleman already. So any question about this, as it is complicated?
Sir, a nephrectomy scar, how long it is?
Yes, a nephrectomy scar actually it is around 8 to 10 centimeter scar. It is
And there's mostly in lumbar region, you said.
yes, it's mostly in the lumbar region. Like if you see any patient of a renal stone operation, just like this.
Sir, is there any scar on the back also?
Yes, if any patient have the renal scar, that renal nephrectomy scar or in renal operation, it will extend into the back. So it will be very large scar.
Sorry.
Okay.
So,
Yes, yes.
excuse me, how we can assess the fluid if overload or not?
Yes, because I have already checked the neck, there is no raised JVP. I have already checked the peripheral edema, no edema, and there is no basal crepitation. So I'll check there is no signs of fluid overload.
Okay, thank you.
Thank you.
Fluid overload, actually, fluid overload can also result in ascites.
Yes, it's
And
also ascites. But what I am saying, if any patient with a renal transplant, renal disease already, and without any other organ failure, this fluid overload may be due to a transplant failure. But it may be possible in the other diseases. You are right.
We can say it's a side effect of the treatment indication.
Mm.
My
Sorry?
government feel like that. With
Treatment
complications.
complication. Complications. Yes. In the complication, during examination, I have checked hands so for the any steroid purpura or any tumor that is in cyclosporin use. It may be in any patient of cyclosporin use, it may be impossible of fine tumor. But if it is toxicity, that is coarse tumor, then I have checked already the face. Is there any facial puffiness or swelling of the face? So I'll just, it is not possible to check the all complication of the steroid. I have to check the back, proximal myopathy. Just I'll check one or two or three. Okay, but if anything is visible, that means there is a scar, a viral wart, as well as a scar for basal cell or squamous cell carcinoma. At that time, I will say that there is a scar. Or sometimes we will find the unusual ulcer, maybe from the Kaposi sarcoma, as patient is immunocompromised. At the time, I will say this.
excuse me, these viral warts are mostly in neck area or any other areas?
It's all over the body.
All over
Usually
the
it is
body.
all over the body. Yes. Okay. So hello.
This fluid overload, we at the spot we will check for the JVP and basal crepes and these are the sufficient. Two things are the two places are or tests are sufficient for comment about the overload.
Yes. For the fluid overload, I will check the only the, if you want to check the JVP, it will take times. The reality is that. Yeah. Oh, I have already checked the peripheral edema and I have already checked the basal crepitation. So I will only do this two.
Okay. Thank you very much.
Thank you.
Sir, regarding ascites, we will check only on one side, right? You said.
Yes, yes. If there is ascites, we'll check only the one side because by definition, ascites is free.
And sir, if it is tense ascites, they give an exam, then we will check supine position, not shifting.
If it is a state, just you will check the fluid thrill.
Yes.
But the thing is that if you will find many patients, both fluid thrill and shifting thrill is same is positive. Both two things is positive.
They give such patients fluid thrill point.
No. Just I will say they will try to identify what I say. It is ascites or not.
Okay. Yes.
Okay. So this is the description of the renal transport case. So I have to be very much careful in my description. There may be current mood, previous mood, as activity, that means functioning, and as well as any complications present or not. Okay, and I cause. If it is PKD, I will say the cause directly. Okay, so what are the common question asked in this in this station or in this renal transport? Another, sorry to say, another important thing that you will find some patient only with the AV fistula scar. Okay, only with AV fistula. Okay, that means AV fistula scar, everything is normal. Everything is normal, or you may get only the anemia. AV fistula scar, everything is normal, or only anemia. So how will present? Just say on examination, no finding in the abdomen. Okay, this is the case of simple CKD patient on maintenance hemodialysis. That means CKD patient on maintenance hemodialysis. CKD patient is maintained hemodialysis. However, this only patient is getting dialysis through AV fistula and only the anemia. So on examination of the gentleman, I found that there is a AV fistula, arteriovenous fistula in the right hand, which is functioning, and there is a signs of recent use. There will be needle mark, and there are some scar over the neck and also in the tummy, which indicates previous access for the hemodialysis. And this gentleman also have anemia. There is no features of fluid overload. Okay, and abdomen examination, I did not find, I could not appreciate any organomegaly. As this is the abdominal station, I will say that. Okay. So this, my diagnosis, this is a case of chronic kidney disease with maintenance or adequate hemodialysis. So chronic kidney disease with maintenance hemodialysis. Okay. With, if the patient is anemia, I will say anemia. It's possible this patient has anemia as well as high blood pressure. So this is a case of CKD. It also comes in the exam. Only simple CKD case. Now, regarding the questions again, the first question is what are the differential diagnosis of this mass? So how you are so sure this renal mass or any other thing? Why I'm so sure? Because on examination, there are some features of renal treatment. That means patient is AV fistula scar, patient is neck scar, that means dialysis, it's patient. So most possibly there is no signs of resource use. So this is, I'm sure this is a renal transplant. Now this transplant is acting good, so there is AV fistula scar is not in use. But what are the other differential diagnosis of this mass? So DD of transplant mass. What it will be? It will be, number one is transplant kidney. Number two, it may be appendicular lump. It may be colonic mass. It may be ovarian mass. Case of a female patient. It may be Crohn's disease. It may be lymphoma. It may be a mesenteric mass. So I will just say three or four. So it may be, what are the differential diagnosis of this mass? Number one, transplant kidney. It may be appendicular lump. It may be a colonic mass. It may be ovarian mass, Crohn's disease, lymphoma. It may be mesenteric cyst. So I'll say this. Now examiner will ask the question, what are the why you are so sure this transplant kidney is acting good? Number one, there is no signs of fluid overload. So why you are so sure that transplant is functioning? Transplant is functioning. Transplant is functioning. Number one is no signs of fluid overload. Number two is no signs of uremia. Okay. And another thing is that if this transfer fail, you will find some recent signs of renal replacement therapy. That means patient, I am a patient of chronic transplant kidney. Now I have developed my failure of my transplant kidney. So what you will do, nephrologist is put a catheter into my neck, or he will put a needle into my AV fistula. So there is number 3 is no recent renal replacement therapy. So why I am so sure that transplant kidney is functioning good? Number 1, no signs of any fluid overload, no signs of any uremia, and no recent renal replacement therapy. Okay. Then you will ask some other question, like what are maybe the complication of this transplant kidney? What may be the complication of this transplant kidney? Complication means some local complication, some local is infection, or it may be and another complication is thrombosis. That means obstruction of the transplant vessel. Transplant vessel may get obstructed. And rejection may be many types: hyperacute rejection, acute rejection, chronic rejection. It may be many, but local infection, thrombosis, and rejection. Hence, another complications is due to drug related complications, especially diabetes mellitus, hypertension, increased chance of ischemic heart disease. All transplant patients have this. Okay, so diabetics, hypertension, ischemic heart disease, Cushing syndrome, iatrogenic, and lastly, some complication or side effect of the medication. Another side effect of the medication is skin complication. So skin infection is very common. It may be some basal cell carcinoma, squamous cell carcinoma, Kaposi sarcoma, viral wart, okay, even malignant melanoma. So skin infection is very much common. So basal cell carcinoma, squamous cell carcinoma, Kaposi sarcoma, viral. In my exam, there is a patient of transplant kidney, and that patient is having transplant kidney along with viral wart all over the body. I say only transplant kidney, and they give me 10 out of 20. Okay, so that was a transplant kidney along with viral wart. So you have to be very much careful. This basal skin complication, basal cell, squamous cell, Kaposi, and viral wart, and even also melanoma. So those are the complications. Because all why hypertension, those are so common, because a patient is already getting the steroid and cyclosporine. So cyclosporine, if any cyclosporine, what causes? Cyclosporine causes high blood pressure, high blood glucose, hypertrichosis, and hypertrophy, gum hypertrophy, and hyperkalemia. So all those are the features of cyclosporine. So it is very common. Patient of renal transplant is having this high diabetics, hypertension, ischemic heart disease, and iatrogenic Cushing also. Okay. Now, so this is the examiner will ask the another question. Actually, what is the investigation? How we will going to investigate this patient? Okay, so how we will going to investigate this patient? So investigation, what you will check, like here you will do the investigation. You will do the renal function test. That that is urea, urine for routine and microscopic examination, serum urea, electrolyte, creatinine. Yes, serum urea, electrolyte, creatinine. You can check the creatinine clearance test, okay, to check the GFR. Okay. If you think now, one of the complication is infection, so you can check the CBC, CRP level. Okay, if you think this is an infection or local complication develop, what you will do? You will do the biopsy. So biopsy, and important complication is thrombosis of the vessel. So for that you will do Doppler scan of transplant vessel. So Doppler scan of transverse vessel. It's like the you are managing the patient of mitral valve replacement. YOLO book. You are saying the YOLO book. So in case of the renal, if you think this is the case of renal transplant, you always try to say this Doppler scan of the transverse vessel. It's a very common investigation, usually done immediately after renal transplant to see the patency is intact or not. So Doppler scan of the transverse vessel. Lastly, what you will do, you can check the viral screening. You can check this infection screening as a whole, because you will check mostly cytomegalovirus, parvovirus, all screening. So infection screening. The other thing is drug level. Drug level. You will find that patient is cyclosporin. Cyclosporin requires drug level monitoring. So you will do the drug level. So all those things are the investigation of renal transplant. Starting from the renal function test, CVC, CRP, biopsy, Doppler scan of the transverse vessel, infection screening, and drug level lastly. Okay. Now, sometimes examiner will ask that how will you, why this kidney is transplanted into this area, that means in pelvic area. Why into the pelvic area?
Space and vessel.
Yes, good. So it is due to good vascular supply. Good vascular supply. Good vascular supply. So anastomosis is easy there. Number one. Number two is adequate space. There is an adequate space there. And another thing is close proximity to the bladder. It's a bladder. So ureteric anastomosis, both vascular and ureteric anastomosis is easy. And another thing is easy to do the biopsy. Easy to do biopsy.
Sir, what are the indication for the biopsy in original disease recurrence or?
Yes, you are right. If any patient develops transplant failure, you will do the biopsy, needle biopsy. There is a possibility of you can identify hyperacute, acute, or chronic reaction by seeing the cell, as well as you can identify the or recurrence of the original disease. If it is focal segmental glomerulosclerosis or mesenteric-capillary glomerulonephritis, then there is a high chance of recurrence of original disease. So those are the causes of the advantage of the pelvic area. And another thing is that the disadvantage that is easy is it is a superficially. So it's a problem is that there is a chance of trauma. So there is a chance of trauma. Okay. Now regarding the management again, patient education, counseling, exploration of the disease, formation of the multidisciplinary team involving my consultant, kidney doctors, social worker, occupational health therapist, physiotherapist. So I will do, this patient is a renal transplant patient. So I will do regular clinical and laboratory follow-up this patient. Okay, and just I will say this, I will do the regular clinical and laboratory follow-up, and patient require a lifelong immunosuppressive therapy. Okay, so here no specific management other than this. Okay, so this is the renal transplant. So any question regarding this renal transplant?
Yes, sir. The last line I missed. You said chance of trauma is less in pelvic, right?
Oh, no, okay. It is placed superficially. So there is, and the pelvic area, so chance of trauma is actually more there.
More. Okay.
Which is the disadvantage in the pelvic area.
Side effect, right? If we
Yes. So any question about this renal scar or renal transplant?
Actually, this in the pelvic area, less chances of what did you say?
Okay, pelvic area have some advantage, that is good vascular supply, adequate And only
Okay.
one disadvantage, actually it happens in any other of the abdomen also. So it is placed superficially, and it is a chance of the trauma.
Excuse me, sir. Hello.
Hello.
Before transplantation, do we remove already existing diseased kidneys, or we left them in their original
Yes.
space?
If any polycystic kidney disease, if it does not cause any problem, we will not remove the polycystic kidney. It will be there. And if during transplantation, if there is a lack of space, as if you see any polycystic kidney disease, actually you will. When I see first at my polycystic kidneys, I'll say maybe he's a patient of thalassemia or not. There is a huge hepatosplenomegaly like presentation, but it is bimanually palpable, no respiratory movement. So it's actually very huge. So it's sometimes due to give some room or space to the transplant kidney, you can remove the right-sided nephrectomy. Or if any recurrent infection, stone, or any mechanical complication develops, you can remove the kidney.
Sir, you said recurrent infection in the
Yes.
transplant.
No,
Mesenteric
recurrent is but in the polycystic kidney disease. In the cyst, recurrent infection, hemorrhage in the cyst. Then
Yes,
I could remove the, I will do cystectomy or nephrectomy.
And so you said in transplant kidney there are chances of recurrence of focal and
Yes.
mesenteric-capillary. What else?
Yes, yes.
Polycystic can recur also? Polycystic.
Okay. There are some causes of failure of the transplant. Failure. Number one is simple cause is rejection, failure. Why there is a failure of transplant? Number one is a rejection. It may be rejected, hyperacute, acute, or chronic rejection. So number one is rejection. Then number two causes infection. So rejection and infection. Then it's a possible of that is a thrombosis of the vessel. It may be possible to trauma. And lastly is reappearance of the primary disease. Reappearance of the primary disease. Okay. What are the common causes here? Focal segmental glomerulonephritis, mesenteric-capillary glomerulonephritis. So those is a high chance of reappearance. Because it's antibody mediated disease, patient blood is already antibody. So there's the appearance of the primary disease. Those are the common causes of the failure of the transplant kidney.
Excuse me, what is the chance of IgA
It is less.
less?
IgA nephropathy, yes. And
it is there, or they are saying that it is recurrence is more common, but it is less as compared to any.
Yes, recurrence is common, but here it is less than compared to focal segmental or mesenteric-capillary glomerulonephritis.
Okay, thank you.
So polycystic is not so much recurrence.
Yes, polycystic is no recurrence.
Okay.
And most common cause is CGF, the chronic glomerulonephritis, no recurrence.
Thank you, sir.
Okay. Then other is like diabetics, hypertension. Okay. So this is the renal scar. So now I will discuss another scar, that is liver scar. Okay. So any other question up to renal transplant?
So just wanted to add the chances of lymphoproliferative disorder also.
Yes. You can tell it. A lymphoproliferative disorder, as patient is taking immunosuppressive.
Lymphomas, yeah.
Lymphoma is one of the complications. Okay. So we have to be very much careful about the renal transplant, as it is very much common.
Sir, after renal transplantation, what's the life of those transplanted kidneys? Is it lifelong or like 10 to 20 years with immunosuppressant therapy and without immunosuppressant therapy?
Actually, I don't know specifically what is the expect lifelong of the transplant kidney. Um, but patient should have immunosuppressive therapy in all transplant kidney because kidney is highly vascular. So patient should have immunosuppressive therapy. Most of the patient is taking 3 immunosuppressive. Find mostly 3: prednisolone, cyclosporin, and sometimes we call azathioprine or mycophenolate mofetil. Mostly mycophenolate mofetil.
Yes.
Oh,
Also cyclosporin with
Yes,
tacrolimus.
yeah, tacrolimus also.
Yeah. Thank you. Thank you.
Thank you. Okay. Now, just I'll discuss another scar, that is liver transplant scar. Okay. Liver transplant scar actually very high. Okay. So other scar in the abdomen is liver transplant scar. I'm not going to say it as a liver transplant. That is a scar. Then patient, you think this is a patient in the right subcostal area. There is a scar. Okay, just like this. So this is a patient. There is right subcostal area. There is a scar in the right subcostal area. Okay. Now, what you will say in the exam? Apart from this, patient is completely normal. You will check the hand, it's normal. Eye, no sign. Oral cavity normal. Neck normal. Chest normal. Abdomen no ascites. Only this scar. This scar, and no peripheral edema. Everything is normal. Now think about the general thing. Okay, so this scar may, if they extend into like this, or if you find this type of scar, this is Mercedes Benz scar. This you are very much sure this is a liver transplant scar. But the thing is that this Mercedes Benz scar is not commonly used because it's mostly done in the right-sided rooftop incision or right-sided rooftop incision, or you are get some scar in the right subcostal area with extension into the sternum. But very classically, initially it was done with the Mercedes Benz scar. Okay, so you are getting this source of scar, and now saying the what is your finding? So this is another scar in the abdomen. So what you will say? I will say on examination of this gentleman, there is a right-sided there is a scar in the right hypochondriac region, or you can say right-sided rooftop scar. Okay. If you find the liver, okay, see liver may be palpable. Think this is a liver transplant, so there is a possibility liver is palpable, or sometimes it may not be palpable. It depends upon the bulk of the transplant liver, cases or the previous size of the patient liver. So it depends actually, or where it is a transplantation. Okay. So there is a possibility you may get the liver or may not get. If get, you say there is a hepatomegaly, which is 2 finger by 1 finger breadth from the right costal margin, non-tender firm in consistency, moves with respiration, upper body in the right fifth or intercostal space. There is no hepatic break. Okay. If you get this scar and no liver, it is common. Just you will say, what is your diagnosis? My diagnosis, this there is only the scar in the liver, the right-sided rooftop scar. Apart from that, I could not find any other problem, or I could not find any organomegaly. Okay, so you have already checked the hand. In hand, no sign, no stigmata of chronic liver disease. Okay, you have checked the eye for anemia jaundice, no anemia jaundice. In the you have organomegaly, there is no organomegaly. So you can find this type of scar. Now examiner will ask the question, what is the differential diagnosis of this scar? Okay. Now the thing is that if you only focus on the liver transplant, actually you will lose your mark. Okay, it may be due to thing general. It may be due to a lot of disease. It may be due to cholecystectomy. It may be that is open method, or it may be due to gastric surgery. It may be colonic surgery, or it may be liver transplant. Okay, in liver transplant, if you think the liver transplant, what are the most common causes? Number one cause is it is acute liver failure, due to acute liver failure. In patient of acute liver failure, if you do the liver transplant, he will not be any feature. He will be completely normal. Okay. And another thing is that this transplant liver is cut down from someone. So it may be donor liver also. So it may be donor liver, it may be transplant liver scar, donor liver scar, or a transplant liver scar. As well as I will say it may be due to some other surgery, like gastric surgery, colonic surgery, gallbladder surgery. Now examiner will may ask some question. What are the cause of this liver transplant? So what are the cause of this liver transplant? So what are the cause? Number one cause is acute liver failure. Acute liver failure. It is already number one cause. It may be drug related cause, that is a paracetamol poisoning, or it may be viral hepatitis, acute fulminant hepatic failure. Viral acute fulminant hepatic failure. So it may be a drug related cause like viral hepatitis or acute fulminant hepatic failure. Then other cause is it may be other cause, that is chronic liver disease. So acute liver failure, chronic liver disease. In chronic liver disease, when it is complicated with some other disease like hepatic encephalopathy, then hepatorenal syndrome, hepatopulmonary syndrome, drug resistance ascites, then we'll do the liver transplantation. Or it may be some other cause like a PBC and PSC with specific feature. That means serum bilirubin more than 100, stage encephalopathy. Okay, at that time, we'll do the liver transplant. Okay, and in cancer, it is very rarely done. In cancer, actually, liver transplant is very rarely done. Okay. So, what are the cause again? Acute liver failure, chronic liver disease, PBC, PSC, cancer, very rarely. Now we'll do how we're going to manage this patient if this is liver transplant. I will say just investigation, liver function test, and also all the liver function tests. Then I will say the screening for any screening. Screening includes the viral screening. So regarding the investigation, all the liver function tests, always say 5 things in one. Like what I will say, serum bilirubin, number 1, AGPT, ALT, alkaline phosphatase, serum albumin, AG ratio, just or up to serum albumin. This then screening. Screening means viral screening. That means HBS, AG, NT, HBC, IgM, and G, and then NT CV. Okay. Now management. Again, patient education, counseling, explanation of the disease, formation of the multidisciplinary team, involving my consultants, hepatologist, social worker, specialized nurse. And I will say just one thing is very much important, that vaccination. That is vaccination against the hepatitis B. So I'll say here I will vaccinate the patient against hepatitis B virus. Okay. So I can vaccinate also against the hepatitis A virus also. So I will vaccinate the patient against the hepatitis B virus, A virus. Why? Because this is a case of liver transplant. See, if any, I will not allow any infection. Yes, I can say the PTIN also. Okay, so I will not allow this patient. Okay, so I management, I will say everything plus vaccination. It's very much important. Okay, so this is a simple liver transplant scar. In abdomen, you will find some another scar like only the nephrectomy scar also. So and only the nephrectomy scar. So in nephrectomy scar, just there is a scar in the right lumbar or left lumbar region. I will say just there is a scar in the right or left lumbar region. Apart from this, I could not find or appreciate any organomegaly. So my so why there is a scar? It may be a nephrectomy scar. I will say nephrectomy scar. Number two is it may be any. Yes, regarding the vaccination, in liver transplant, I will always say vaccination. That means vaccination against the hepatitis B virus and A virus. Because I will not allow any infection in this transplant liver. Okay.
Sir,
Yes.
sir, what complication reoccur after liver transplantation?
Yes. Actually, complication. This procedure actually does not have any complication. Like other procedure, it may be bleeding, infection, but it is not a specific complication like the renal transplant. In liver transplant, immunosuppressor usually gives it very minimal amount, and most of the time, very minimal amount.
Doctor, no rejection?
Yes, no rejection.
Excuse me, doctor, regarding the rejection of the transplant, what is the frequency of rejection? How we can classify like renal transplant and this cardiac or this pulmonary with the this liver transplantation? How they are? Most common is the kidney, and then this. How is the sequence we can see?
Yes, actually, it depends on the organ, organ or its blood supply, and as well as some integrative characteristics. So, in case of the just you can say if the avascular structure is avascular like cornea, it does not need any. But in the case of the vascular such as kidney is the highest, as well as it's a highest rate of failure. So it depends specific immunogenicity. Actually, I don't know, but in case of renal transplant, patient requires a higher dose of immunosuppressor agent. But other liver transplant, just what I'm giving my personal experience. One of my uncle has done this liver transplant. Is due to NASH, non-alcoholic steatohepatitis. He does not take any immunosuppressant, and he has done it around 10 years back, and now he's completely fine.
Donor is the relative?
Donor is not relative.
Okay. Very good. Very good. Ideal situation. Mashallah,
In
very good.
NASH, the outcome is very good in NASH. Okay. So some other scar, nephrectomy scar. So I will just say the it is very rare, right lumbar region or left region. But here just I will learn DD of this scar. So in nephrectomy scar, what I will get I say only the nephrectomy scar. Apart from this, normal. So it may be nephrectomy due to maybe renal cell carcinoma, or it may be cystectomy. It may be polycystic kidney disease, or it may be adrenalectomy. So renal operation and adrenal operation. So nephrectomy or adrenal operation. So I'll just say this. Examiner, I will ask some question. Okay. Lastly, there is a splenectomy scar. Splenectomy scar. Okay. Regarding the splenectomy scar, so we'll found patient age is young, and there is a large scar over the gastric as well as the midline. And this scar sometimes we'll found this scar sometimes extended into the right right hypogastric region. Okay, right subcostal region. Actually, this splenectomy scar will found a patient of congenital hemolytic anemia. Yes, splenectomy done in other operation also, that's like in abdominal trauma. But mostly this is the patient of congenital hemolytic anemia. In congenital hemolytic anemia, there are two reasons for surgery. Number one is splenectomy, another is cholecystectomy. Usually patient when you do the splenectomy at the same time they did the cholecystectomy. So there is some extension of this. This scar is called the hockey stick scar. So hockey stick like incision, and at the day they did the spirochectomy as well as the cholecystectomy at the same time. So examiner will apart from this, actually I will not find anything. So what examiner will ask the question, what are the indication of this splenectomy? So what are the indication of splenectomy? Here important thing is that what I miss, you find some features of some features of when you do the exam. You'll find during you'll examine that first hand, you'll not find anything, you'll find anemia. There is a anemia. Okay, so I'm going down, you find also jaundice. And after that, if you if you see the face, there is a characteristic facial feature for thalassemia. In abdomen, you'll find there is a hepatomegaly plus scar. That means splenectomy scar. So you have to say all those things. Okay, you have to say all those things. Just like on examination of this gentleman, you may start from the hair, you may start from the scar, or start from what you have already get. Just in hand, no finding. In eye, there is a anemia as well as jaundice. And this gentleman is also have characteristic features suggestive of congenital hemolytic anemia. On abdomen, there is a scar. There is a, you can say there is a hockey stick scar, or there is a scar which is the upper part of the abdomen. Okay, and there is also hepatomegaly. There is also hepatomegaly, which is 1 or 3 finger bed, not tender, firm in consistency. Upper border of the liver dullness is right as 50 intercostal space. There is no hepatic bruit. Here, splenectomy scar, what I will say, I have already seen there is a splenectomy scar. Okay, I will say there is a absence of dullness in the right lower intercostal space. So what I will say, there is an absence of dullness in the right lower intercostal space. So what is your diagnosis? By diagnosis, this is a this gentleman is having splenectomy along with congenital features of congenital hemolytic anemia.
Sir, you said absence of dullness in right
Left.
lower
Right
left.
lower intercostal
Yeah.
space.
Left, sir?
Left.
Oh, sorry, left lower intercostal space. So there is absence of dullness in the left lower intercostal space. That indicates as splenectomy. Sorry. So I will say along with this, so features suggestive of congenital hemolytic anemia along with the splenectomy. So in case of congenital hemolytic anemia, why splenectomy is done? When it causes some, number one is mechanical problem. When it causes some mechanical problem. Okay, so when it causes some mechanical problem. Number two, features of hypersplenism. And another thing is that increased requirement. Okay, so more than, if the increased requirement is more than 50%, then we'll do the splenectomy. Actually, how it's calculated, it's very easy. It is compared to the previous years. Okay, so what is the I will take the history previously.
What requirement?
What requirement increase
Transfer-
requirement of blood, you said?
Increased requirement of blood transfusion. Requirement of blood transfusion. In congenital hemolytic, increased requirement of the blood transfusion. I will ask the patient. Previously, he takes around 1 bag in 2 or 3 months. Now he is 1 bag in each month, or 2 bag in each month. Then it is requirement is increased. So I will do the splenectomy. Or the mechanical complication. That means patient is early satiety and vomiting, nausea. Then I will do the splenectomy. As well as if any patient develops any trauma to the spleen, he will undergo urgent splenectomy. Okay. Okay, so this is the splenectomy. In case of splenectomy, again, the what regarding the ask the investigation. Here, no specific investigation. Ultrasonography of the abdomen. So no specific investigation, but you can do the investigation for the congenital hemolytic anemia. Just complete blood count along with the peripheral blood film, along with hemoglobin electrophoresis, iron profile. You can check repeated blood transfusion for infection screening, hepatitis B, C. So you can check this, but no specific investigation for the specific apart from ultrasonography. So I'll start ultrasonography of the abdomen. And lastly, regarding the management, again, the same management, patient education, counseling, exploration of the disease, formation of the multidisciplinary team that involve my consultant, hematologist, social worker, occupational health therapist. Here, as the patient is speaking to me, I will vaccinate the patient. So if the patient is already vaccinated, so I will continue that. And another important thing that perioperative patient, I will give the bracelet, medic alert bracelet. And I will medical alert bracelet, any medical alert bracelet. In some days we give the medic alert bracelet like Edison disease. In spiritual, I also give some medic alert bracelet. Anytime this patient develop a meningitis, at that time this bracelet will give some clue. Yeah, meningococcal septicemia. Okay. Lastly, in spiritual patient, I will aggressively treat the dog bite, which is also okay. So I will say everything, but I will focus on the vaccination, that will pneumococcal, meningococcal, but that is capsulated vaccination. And I will focus on the medical alert bracelet, and lastly, aggressive treatment of the dog bite. Even it is mild, then I will do. I will give the tetanus as well as I will do aggressive treatment with antibiotics. So those are
What is the last
dog bite. Aggressive treatment of dog bite.
after next? Huh?
Yes, if any spiritual patient having the history of dog bite, then I will treat it aggressively with injectable antibiotics.
Excuse me, this dog bite for
Rabies?
No, not rabies. If
related organisms?
yes,
Just
there is a sub-organism in the, I could not remember this time, in the dog mouth, so that can cause septicemia in the spiritual patient.
Yes, okay.
So I will aggressively treat the dog bite here.
Okay. And,
So yes, okay. Thank you.
one question, this is a general question. Whenever there is a when there is an increase in the size of spleen,
Yes.
is it always associated with hypersplenism, or even we can see that the patient don't
Okay.
have the, what is your idea about this?
Okay. The idea is that this patient has congenital hemolytic anemia. There is an increased size of the spleen, but at the same time, you need to check the check the function. That means CBC. If CBC there is no features of pancytopenia, then the size is increased, but rather the sizes have already increased, but the CBC function is normal. Okay.
Yes.
As there are some extramedullary hemopathy, the speed is increased. But when the features of pancytopenia, that is increased size and function, then it is hypersplenectomy.
Okay.
And another character, this pancytopenia should be reversed after splenectomy. So you have to do the splenectomy to confirm it is a features of hyperplasia. So after splenectomy, everything will be normal. It is also another features of hyperplasia. Okay, so we have discussed the different scars today. So in another day, we'll discuss the hepatomegaly, we'll discuss ascites, and we'll discuss the PEG tube.
Okay,
So any question? Yes.
Did you complete this CNS? You discussed one lecture.
No. Yes, it actually it's not possible to cover. Next session, I will discuss cranial nerve and what are the common cases in the cranial nerve.
Yes,
Parkinson disease. Parkinson disease. And
Please
some,
discuss.
yeah,
Your
yes.
neuro session was very helpful, sir. Please discuss more about CNS also.
Okay, thank you.
Okay, thank you very much.
So please discuss stroke like crossed and uncrossed hemiplegia. Those are important topics.
Okay, inshallah.
Neuro
Inshallah,
is
we'll
very
discuss everything.
difficult, sir. Yes, your informative session helps us a lot.
Okay,
Thank you.
thank you.
Thank you, sir.
So thank you everybody for
Thank
participation.
you, Dr. Shovan. Thank you very
Assalamu
much.
alaikum.
Thank you, sir.
Yeah, well.